Hello everyone, welcome back to the Case in Sports Cardiology. I'd like to welcome my co-chair, Dr. Jonathan Dresner, who has an international reputation in sports and exercise medicine and is the editor-in-chief for the British Journal of Sports Medicine. Welcome, Jonathan. We have an expert panel as well, Professor Antonio Pliccia from Rome and Professor Maite Tome from St. George's, who will be participating in the discussion of these excellent cases. So without further ado, I'd like to introduce our first case, which will be presented by Dr. Saad Fyyaz, who is a PRI research fellow at St. George's. Saad, over to you on your interesting case.
Thank you very much. Good afternoon, everyone. And firstly, a huge thank you to Cardiac Risk and the Young for inviting me to speak this afternoon. So my case is entitled Devil in the Detail, and without further ado, oh, hang on, I'm having... Okay, so the case background begins around Luke. Luke is a 17-year-old black athlete. He's an elite athlete who plays American football. He's entirely asymptomatic of any cardiac symptoms, and in fact, he's considered amongst the fittest within the academy. He has no past medical history, he's a never smoker, and does not participate in any illicit drugs without any known family history. He attended for a routine cardiac risk in the young screening, and this is his 12-lead electrocardiogram. And I won't describe it, I'll just give the audience a second just to absorb that. And move over to the first poll. Let's begin. So what is the ECG suggestive of?
So I believe most of the audience have stated hypertrophic cardiomyopathy. Some are still thinking about arrhythmogenic cardiomyopathy. We've got 10% for normal physiological adaptations in black athletes, 8% juvenile pattern.
Okay, excellent. So nice spread of answers. So I'll just go through the 12-lead ECG, which demonstrates sinus rhythm with inferolateral T-wave inversion with preceding ST depression, most marked in V4 to 6. And that is very much in keeping with an abnormal ECG. So in line with the 2017 international criteria for ECG interpretation with athletes, you will find T-wave inversion in the abnormal findings box, and therefore this recommends further evaluation. So he proceeds to a transthoracic echocardiogram, and I'll load the pictures here for you. And this is reported to demonstrate a normal cavity size, basal septal hypertrophy, the maximum wall thickness of 13 millimeters with normal diastolic indices, normally sized atria, no valvulopathy, and normal left ventricular systolic function. He proceeds to be referred up to St. George's University Hospital for further evaluation and undergoes a 24-hour Holter, which demonstrates sinus rhythm throughout, with some episodes of nocturnal and diurnal sinus tachycardia, but without any activity and a normal heart rate profile. He completes an exercise test undertaking 14.5 minutes of Bruce protocol with an appropriate heart rate and blood pressure response. There were 2 ventricular extrasystoles at moderate effort, but no evidence of ischemia. He undergoes a cardiac magnetic resonance imaging scan, which the video should be playing again. I'll just let that run a second. But normal biventricular systolic function, and once again confirmed a maximum wall thickness of 13 millimeters at the basal anterior septum without any late enhancement or scar. So far we've got an asymptomatic elite athlete with an abnormal ECG, a normal heart rate and blood pressure response on exercise, and a cardiac MRI that demonstrates 13 millimeter maximum wall thickness. At this point, there is a slight family history update. were advised that Luke's mother underwent a previous private medical abroad and was noted to have an abnormal ECG. She was comprehensively evaluated and told that she had normal investigations. So we invited Luke's mother for a 12-lead ECG, and this is the 12-lead ECG of Luke's mum, which again demonstrates deep inferolateral T-wave inversion with preceding ST depression. This is Luke's mother's cardiac MRI. And perhaps I can just invite some comment on these MRI images from the panel.
Professor Pelliccia, what do you think?
Okay, so far, and the case is very intriguing. So far, everything looks forward for hypertrophic cardiomyopathy. In other terms, the issue on the floor is hypertrophic cardiomyopathy, yes or not. And specifically, the presence of abnormal EKG either in the athlete, in the mother, together with these images, specifically in the mother, are highly suggestive for some form of hypertrophic cardiomyopathy, apical or, say, subclinical hypertrophic cardiomyopathy, so far. Then let's see what's occurred.
Excellent. So I mean, yeah, exactly. That's what I was hoping you would go for. So I just want to speak briefly about why a diagnosis of hypertrophic cardiomyopathy matters. So in this US registry, in fact, almost a third, if not more than a third of causes of sudden cardiac death were attributable to hypertrophic cardiomyopathy. And we know that there is an overlap between hypertrophic cardiomyopathy and the athlete's heart. So indices which favor athlete's heart are left ventricular cavity dimension of more than 55 millimeters, normal diastolic filling indices, male sex, regression of maximum wall thickness on detraining, no family history of hypertrophic cardiomyopathy, and an excellent maximum peak VO2 of more than 45 mils per kilo per minute favors athlete's heart. In this case, we note that there are potentially bizarre ECG patterns and a family history of hypertrophic cardiomyopathy in Luke's ECG, which may favor a diagnosis of hypertrophic cardiomyopathy. Just briefly reviewing some of the discussion around the black athletes' maximum wall thickness and transthoracic echocardiography. There's a study by Sandeep Basavaraja and colleagues from St George's University, which demonstrates that up to 18% of black athletes actually demonstrate a maximum wall thickness of more than 12 millimeters, and Luke very much falls into this category. So if I can move to the next poll, what are the implications for Luke?
Okay, so if the audience can start voting. So people are still voting, I believe.
Excellent. So I'll just run through the options. So have we got enough information there to diagnose Luke with hypertrophic cardiomyopathy, but say actually he is low risk and that he can continue elite sports? Or are we going to say this is hypertrophic cardiomyopathy, there's a risk of sudden cardiac death, and that he should be recommended for exercise restriction? Equally, is there some ambiguity? Could this still overlap with athlete's heart and maybe we should just continue to monitor him? Or actually, do we have enough to say this is athlete's heart, we're reassured by all of this, and let's discharge Luke from any further follow-up?
Jonathan, what do you think from the American side of things? I presume the American guidelines differ from the European guidelines. What's your opinion on this without giving the case away?
Sure. You know, first of all, you know, this is a perfect case to discuss, right? So fabulous presentation thus far. And there we go. Sorry about that. First of all, this is just a perfect case to present. It's so challenging. Everything seems to be sort of in that gray zone of uncertainty. And do we really have enough here to make the diagnosis right now? Do we need to follow over more time?
Okay.
So I'm afraid I can't see the poll live to know what the results are.
Let's see the results. So the vast majority have voted for athlete's heart versus HCM, continue to monitor, 64%. 24% have said diagnose HCM, recommend exercise restriction. And you've got 12% diagnose HCM, continue elite sport, and none for probable athlete's heart.
Okay, excellent, fine. Again, a nice spread of answers. So I'll just briefly talk about the benefits of exercise. There are a plethora of benefits of exercise across several systems, which you can see here. So actually, exercise restriction in hypertrophic cardiomyopathy is not to be taken lightly. The previous 2014 European Society of Cardiology guidelines in fact were quite conservative, and they advised against participation in competitive sports and discouraged those with hypertrophic cardiomyopathy from participating in intense physical activity, especially where there are risk factors for sudden cardiac death or left ventricular outflow tract obstruction. More recently, however, the 2020 guidelines are somewhat more progressive, and they advise that systematic restriction from all competitive sports is probably unjustified, and in fact go on to recommend a more liberal approach to some. And the reason for this is that, of course, the previous guidelines were a relatively homogeneous definition relative to a heterogeneous disease. So you'll see here that the American guidelines were perhaps slightly more permissive for a period of time, but increasingly the European guidelines also allow for exercise in those with low-risk hypertrophic cardiomyopathy. In fact, very recently, Joy Basu and colleagues, again from St George's University Hospital, followed up some 53 predominantly male Caucasian athletes, at least half of which were competing as professionals, and they underwent 6 to 12 monthly assessments over a 4.5-year period. Now, most of these athletes were assessed because of an abnormal 12-lead ECG, a quarter were due to symptoms, and 10% were picked up from a family screen. I would emphasize that all of these athletes had a low 5-year risk score, and approximately 40% had scar evident on cardiac MRI. One of these athletes went on to have an implantable cardiac defibrillator, but ultimately the message from this study was that the mortality rate in low-risk athletes with hypertrophic cardiomyopathy who continue to exercise are perhaps at no greater risk than in the general population. The caveat is that you need to keep in mind that these athletes were likely competing for several years and are therefore likely a self-selected group who may be low risk to a degree. The American guidelines have provided this very nice summary where utilizing the 5-year hypertrophic cardiomyopathy risk calculator, which computes age, maximum wall thickness, left atrial dimensions, the presence of an outflow tract gradient or a family history of sudden cardiac death, the presence of non-sustained ventricular tachycardia or syncope to give us a risk score. And it would suggest that those who are asymptomatic and have a good functional capacity without arrhythmia can participate in high-intensity exercise. But just one more thing. You may have noticed on the original set of echocardiographic pictures, in fact, I'll invite comment from the panel here as to whether there's anything that they would like to comment on from these pictures.
Maite, what do you think?
Sorry, the muting problem. I'm drawing my eyes to the origin of the coronary arteries.
Amazing.
Yeah, so I see 2 things on the left, perhaps. Am I seeing this right? I don't know.
Amazing. Well, I'm glad there is some question mark, because we proceeded to organize a CT coronary angiogram to just focus on the center circle, which is the aortic root, and hopefully this figure on the right will clarify that the right coronary artery originates from the left sinus of valsalva, just slightly anterior to the left main stem. I'll just let that play one more time. And in fact, it follows a course between the aorta and the pulmonary trunk. And in fact, we proceeded to undertake a stress perfusion cardiac MRI, which he had as part of the original study, without any inducible ischemia. So we know that hypertrophic cardiomyopathy is an important cause of sudden cardiac death, but equally, coronary artery anomalies have been have accounted for a significant proportion of sudden death in a registry from the US military and the National Collegiate Athletic Association. So in fact, Luke has two potential conditions associated with a risk of sudden cardiac death. So I just emphasize his background once more. He's asymptomatic, he's an elite athlete. So far we know he has an abnormal ECG, he has a normal exercise test, he has a cardiac MRI which demonstrates a wall thickness of 13 millimeters with no stress perfusion defect. He has an incidental finding of an anomalous right coronary artery with an interarterial course and a family history of hypertrophic cardiomyopathy in his mother. Just briefly on the anomalous origin of coronary arteries, the true incidence is probably not known. Registry data is predominantly undertaken in patients who are referred for a clinical indication for angiography or CT coronary angiography, but we think it's present in less than 1% of the population. Sudden cardiac arrest or sudden cardiac death may in fact be the first manifestation, and the vast majority of athletes are often asymptomatic. A quick note on the origin of the right coronary artery from the left sinus of valsalva. It is 3 times more common than the left coronary artery originating from the right sinus of valsalva. Despite this, moreover, the origin of the right coronary artery from the left sinus is associated with a slightly lower risk of sudden cardiac death compared with the opposite arrangement. So let's move to the next poll, keeping in mind all of the information I've told you so far. How do you manage Luke now you know he has an anomalous coronary artery?
Okay, so let the voting begin.
I'll just talk through those options. So you have the option of medically managing and just continuing to monitor Luke and just allowing him to participate in sports. Or do you say, well, we have the following findings, maybe we recommend exercise restriction? Or in fact, do you say, let's proceed to surgical correction and a return to sports? Or actually say surgical correction and restrict yourself from any further exercise? I'd be curious to hear the views of our panel.
Okay, so I believe people are still voting, having a think about it. We'll see the results shortly.
Can I ask a question about the cardiac MRI and the CT when thinking about the anomalous coronary artery? I think you're absolutely correct to think that the anomalous right coronary artery has a lower risk of sudden death compared to an anomalous left coronary artery. The specific features of that anomaly also play a role in your risk calculation. And so what else did you see on the cardiac MRI or the CT? Was there stenosis of the vessel? Was there an acute angle turn? And probably most importantly, does that vessel track through the wall of the aorta? Is there an intramural course? And I think it's that intramural course that is probably the highest risk feature and usually more common with an anomalous left. And so wondering if those features might, if you looked for those, and that might also influence the audience and what they choose here on the poll.
Brilliant. I'm glad you asked. I specifically didn't outline those. So actually, there is no acute angulation of the origin of the artery. There is no intramural course. There is no slit-like orifice. And the main finding was that he had a malignant intra-arterial course. But keeping in mind that despite those findings, he had a normal exercise test and a negative stress perfusion cardiac MRI. So he does have at least one adverse risk factor from the anomalous origin.
Professor Pelliccia, what line of investigations do you do in terms of when you identify athletes with anomalous coronary vessels?
Sabia, yes, thank you very much for involving me. I have several considerations specifically. It takes 2 minutes, no more. Number one, echocardiography in athletes should routinely include the visualization of the coronary ostia. This is exactly the case, because in the echo, if there were more attention to the coronary ostia, the diagnosis should be emerged even before. Number one. Number two, Dresner correctly pointed out that the main feature for risk in anomalous coronary artery are the intramural course and the ostium. And I'm not totally sure that here we don't have this feature, because we don't have evidence by CT scan that there was no intramural course. I would like to have better images. And regardless of the origin of the left from the right or right from the left, in individual case, it's very difficult to have an exact risk stratification. That's why the guidelines, the ESC guidelines, does not distinguish left from right or right from left. They must focus the attention on characterization of the anatomical feature of the risk that are exactly the ostium, the slide-like ostium, the intramural course, the interarterial course. If these risky features are present, the recommendation, the guidelines actually recommend not to advise competitive sport, particularly high-intensity sport. But then the management in terms of indication for surgery or not, it's another issue, but it's still very controversial, very controversial.
But when you do find anomalous vessels, which line of modality do you pick in terms of assessing for ischemia? Do you tend to reach out for an exercise test, or do you refer them for an adenosine stress, or an exercise echo? Which line do you go for? Do you go for both?
I think that in athletes the best imaging testing is the echo, the exercise echo, because by exercise echo you can reach a reasonable high heart rate, more than 160, and you may have evidence because usually the windows are quite feasible for a good assessment. You may have an assessment of the global left ventricular motion and the presence of any regional wall motion abnormalities. Other techniques that are mostly used, such as stress MRI or other testing, have the great limitation that are not completely physiologic, and that they are tested and implemented the clinical practice mostly for ischemic disease, atherosclerotic ischemic disease. So this is a field in evolution. We are moving on. In our experience, we do utilize a lot of exercise echo. Otherwise, tomoscintigraphy may be utilized also because of the same issue, that is the potential to have a test during exercise at a relatively high heart rate.
Okay, perfect.
One thing that I would add to what Professor Policia just commented on is I think all of the exercise tests that we'll do are low yield. So none of them are very sensitive to detect an anomalous coronary that really is going to cause a problem. If you have an abnormality on a stress test, then that's certainly concerning, but the sensitivity is rather low. One of the features in this case that I would really talk to the patient about is the presence of chest pain. And I'd really dive into that history with peak exertion, what they feel like. It's not just any chest pain. It's chest pain that occurs really at peak exertion that feels almost ischemic. And then when they stop exercising, it goes away very quickly. And I think there's a character to the type of chest pain that is present in individuals with an anomalous coronary. And I would really go into detail with the patient to see if they have that.
That's a great point, thanks. But can I ask, how would you differentiate whether that pain is as a consequence of his underlying possible hypertrophic cardiomyopathy, or whether that's following on from his anomalous coronary artery?
that's a very difficult distinction, and it may be impossible. But I think that if it occurred only at very peak exertion, that it made the individual stop exercising and that it went away quickly after stop exercising, I think that is more related to an anomalous coronary.
Brilliant. I just want to go back to one of Professor Pelliccia's points. In fact, we did actually identify the anomalous coronary artery, and I completely agree that we must emphasize trying to assess coronary osteoorigin origin on transthoracic echocardiography. And it was, in fact, that particular finding where he had this series of investigations. And again, I just emphasize to the audience as well that, of course, I probably haven't necessarily picked the best combination of CT pictures, but I would just highlight that the key finding was just the artery course. There were no other adverse high-risk markers as far as the anomalous coronary artery goes.
In terms of the results for your question, I think medical management and continued elite sports got most votes at 67%.
67, wow.
Maite has a comment. Maite?
Well, I wanted to say that the most important part of this case is going to be the follow-up and the education of the patient and the family and the expectations. I mean, in some units, for example, even to cases like himself, we are developing techniques like, for example, color perfusion scans that we can see actually that even mild expression of hypertrophic cardiomyopathy tracks with minor changes, structural changes of ischemia. So I think here precision and in testing is actually really, really important. And, I mean, probably those who have been look after young adults or even children, we have been involved many times in other discussions with milking, LAD bridging, and to be honest, the discussion become very similar sometimes because the intramural course is a real problem, and I don't think we have ever sort them out. So I think it would be unrealistic to assume zero risk here, and it would be unrealistic to say that we have evidence to do something other than follow up at the moment in time. So, however, we should follow with intense testing. So that's what I would say.
Okay. Now, I will run through the guidelines momentarily, but given that we have four giants of the world of sports cardiology, I want to put each of you on the spot, if I can, and ask what you would do and why in this gentleman who potentially has two diagnoses associated with the risk of sudden cardiac death.
Professor
If I can.
Pelliccia. Let's start with Professor Pelliccia, who's on my top panel.
Pelliccia Dresner. Well, let's say here we are just not at the end of the case, but let me say, here we have a young athlete, relatively young, which still is asymptomatic, but may become symptomatic. We don't know, so we have to follow. But at the same time, we are just in front with the two conditions: hypertrophic cardiomyopathy, which is, let's say, mild, even questionable, etc., and congenital coronary artery anomalies, which are two risky conditions. So here, I think that the sport is the last condition. Here we have to think about management. How this condition in combination, because this is in combination. So we are thinking, we know about congenital coronary artery anomalies in a normal heart and hypertrophic with the normal coronary arteries, but the combination of both. So I think that it's reasonable to assume that there is an additional risk because of the combination. And that's why I would be very much focused on management. So much more than assessing, let's say, continuation in sports, etc.
So you would advise sports restriction?
Sorry.
I would like to talk about previously about management, which kind of management we should follow, just medical management or surgical one, and then discuss about sports.
We are running out of time with this excellent case, Prof, so we've got to give short answers. Jonathan, over to you.
This is an excellent case. At 13 millimeters, I think the phenotype is still in evolution. And so he clearly has a genetic predisposition with his mother with HCM. You have an abnormal ECG, but do you really have enough for a diagnosis of HCM when the wall thickness is only 13? At 13 millimeters, I think it's preclinical. I think it's still in evolution. I'd prepare the family for what's to come and the importance of serial follow-up, but I would allow him to continue playing sports. I'm not as concerned about the anomalous right coronary artery at this time.
And would you follow him up at 6 months or 12 months?
At age 17, probably 6 months, because I think this is right when it's probably going to get thicker, and we'll see what happens. But I think at this age, probably every 6 months if we could.
Yeah. And Maite, would you let him play? You're on mute, I think.
Apologies. I think I will do every 6 months follow-up. We'll discuss that this is with 13 diagnostic, however, a preclinical status. And at this moment in time, I will shy away for correcting surgically the anomal coronary artery too.
Yeah, me too. I'd let him play, keep him on a close follow-up, and I wouldn't correct the anomalous fascicle either. Okay.
Okay. I'll keep things moving because I know that we're starting to run out of time. I'm going to very quickly run through the 2020 sports cardiology guidelines from the European Society. Now, there's obviously lots of text there, but the key thing here that the European guidelines recommend is that in asymptomatic individuals, that you may consider after adequate counselling, provided there's no inducible ischemia and that there is no intra-arterial course that they can consider playing. Importantly, however, in those who are undertaking competitive sports with moderate or high cardiovascular demand, such as American football, and have an anomalous course between the large vessels, ongoing sports is not recommended. The American guidelines are somewhat more liberal. So if you follow this decision tree with me, which is the anomalous origin from the right coronary artery, that there are no ischemic symptoms or ischemia during diagnostic testing, nor are there any ventricular arrhythmias, they give a 2B recommendation for either surgical intervention or continued observation. Now, I pressed the panel for 4 different views, but of course it is not just the view of the physician involved that's important here. We very much put forward a shared decision-making model involving the athlete, the athlete's family, the club and the manager to allow an informed discussion. So in our case, the case is still very much under review. There's a hot case, if I can put it that way. And the family are just thinking over their options. I think we were not keen to consider stenotomy and surgical correction, given the underlying potential arrhythmic substrate of hypertrophic cardiomyopathy, and we agree that this may very much be a phenotype in evolution as far as hypertrophic cardiomyopathy goes. So in summary, this is a 17-year-old black athlete has 2 potential conditions associated with the risk of sudden cardiac death, and equally each one in isolation has a risk, but the addition of one on the other, 1 + 1 is not necessarily 2 in this case. Risk stratification and long-term surveillance is clearly going to be important, but ultimately shared decision-making is what will dictate how things proceed as far as his ongoing athletic career. Thank you very much.
Thank you very much, Saad. I have one question from the audience, and I'm actually going to direct this to Jonathan. Jonathan, what's your experience about the frequency of false positive suspicion of coronary anomalies on transthoracic echo, not confirmed on CT?
So a false positive versus a false negative, I think it's more common that you just don't see it, maybe in 10 to 15%, where you don't have a clear view of the ostia and you need more advanced imaging. For a false positive, I think false positives are uncommon. If your echo really suggests that there's an anomalous, I think the advanced imaging will usually confirm it. I've never had a false positive in that way, but I'm sure it's possible.
Okay, I think we should move on to the